What's going on, guys, and welcome back to the podcast. Today, we're taking a look on the World's Okayest Physical Therapist podcast of what is a protocol? How is it used? Why do they exist? Just what is it and why does it exist? But first, please don't forget to like, comment, subscribe, follow, share this with everyone you know as I learn to navigate this Byzantine, labyrinthine American healthcare system that's constantly evolving like a Rubik's Cube, fighting back to everybody trying to understand it. And I share my knowledge and insight with you all, so you all better learn how to navigate this crazy landscape that we call the American healthcare system. Ways that you can help the channel. Again, like, subscribe, share, send this to people. The more people that like it, comment, the more people can get access to it, can see it, the more the algorithm will favor us for other people to see it. Also consider joining Patreon and check out 10,000. 10,000 gave me a 15% off link to share with you all on orders of over $60. I am wearing a pair of their shorts right now. I love their shorts. They're extremely durable. I was actually using them just yesterday while I was working on my car, and the things are to say that they are resistant to abrasion and wear and tear is, again, a criminal understatement. So consider giving them a look. The link is down in the description. So what is the why? The why of this episode is to understand a protocol, how it's used, who gives them, and then what they mean. So after a surgery or specific injury, sometimes a person is given a protocol by their doctor or their surgeon that they're expected to follow. That's meant to guide the progression of their recovery. There are many different protocols, and the one that is chosen and given to a patient is usually up to the surgeon or doctor. Sometimes a physical therapist can choose one, but a lot of the time for more major surgeries and things, it's from the doctor or the surgeon. Different surgeons and different doctors have different reasons for choosing the protocols that they do. Case in point, some doctors might favor Mass General's protocol for rotator cuff repair, and others might favor University of Virginia's. It usually comes down to how the surgeon or doctor was trained, which ones they're familiar with, and why for them is a lot of times the most recent scientific studies. So if they knew, for example, that immobilizing a patient for 8 weeks in a sling led to worse outcomes, which I'm not saying that it does, but that's my example, they might choose to go for a protocol that introduces range of motion faster, and maybe at 6 weeks, because then they know that patients have better outcomes. Why? Well, surgeons are interested in protecting their reputation and their success rate, right? A surgeon does not want to have a failure rate of 50%. They want to have a success rate of 100%. So they're going to be trying to pay attention to the evidence to figure out what gets their patients the best outcomes, so that way it reflects well on them so they can stay in business. It's a little bit of a self-serving thing going on there, but it works to the patient's benefit. Just like with PT. PT wants to get you better, and if you don't get better, it looks bad on them. So everybody wants to help you get better. PTs just kind of get Stockholm syndrome, and they want everybody to get better because they end up caring a lot about their patients. Don't listen to a physical therapist when they say they don't care about you. If they do say that, they're like, well, I don't really care about you that much, Reggie. I just do my job. Every PT gets emotionally invested. It just happens. It happens. At the most basic level, protocols help give a person a general guideline expectation when they can return to specific exercises. This is the big why that I want you to take away right here, however many minutes in. The next time you have to go to your doctor, you have to go to a physical therapist, or you have surgery, hopefully you don't, and you say, when can I get back to blah? The physical therapist is going to tell you it depends. It's our favorite saying. We are like some sort of, Vulcan philosopher. Well, it depends. The doctor will usually give you a strict timeline and say you can return to this activity by this week. And what they're referencing is the protocol. The reason why the physical therapist will tell you it depends is it depends if you've met the certain criteria to progress up to that position, up to that phase. So if you fail to be able to bend your knee at all, that means you're not getting back to running, even if you are 8 weeks out past surgery. The doctor will just tell you 8 weeks after surgery, you can return to whatever activity, but the PT is the one that has to make that happen working with the patient. And that's why one medical professional is telling you it depends, and the other is saying 8 weeks. And yes, there is conflict that happens if a patient doesn't get back to doing things within a certain period of time, because then the surgeon and the primary care are very frustrated with the PT, who they believe is failing the patient and them. What is a protocol? Well, like I talked about, it's a structured, evidence-based set of guidelines for managing a specific injury or surgery. Protocols are not general. They're not like, well, you hurt your shoulder, so here's a vague guideline. No, they are specific for whatever injury or surgery took place. They are often created by orthopedic surgeons and rehab researchers. I know PTs give feedback and give input, but really, I think it's those first two groups of people, the orthopedic surgeons, that really make the guidelines for the protocol. So it says here PT professionals as well. I mean, that's what they say, I guess. Maybe the textbook answer is that, but I have not seen a PT develop, create, and implement a protocol. I have seen a PT select a protocol and say, I would like to use this one, and the doctor say, go for it, that works, but I haven't seen a PT create one. Examples of this would be ACL repair, rotator cuff repair, ankle sprain management, meniscus repair. There's so many. The purpose, again, is for consistency. That way, there's consistency across the board. Everybody knows what to expect. Everybody knows how they should be progressing, and it's for safety, right? You don't want to overstress whatever the surgery was, cause a tear, cause injury, and then lose all that progress. And so, of course, there are progression benchmarks to make sure you are progressing safely. So it's structured in phases, phase 1 through phase 4. Of course, the first focus of any phase of a protocol is going to be protecting the surgical site and restoring some form of mobility, but that's almost always exclusively passive range of motion, meaning the physical therapist is going in there and moving the joint for you. Could be a shoulder, could be a knee, could be a hip, could be an ankle. It doesn't matter. The PT is going in there and introducing some motion because, like we talked about in the last episode, with meat versus ice, you want movement, exercise, analgesia, and treatment. That's kind of the principle, except it's the PT doing all those things. That way the patient doesn't hurt themselves. Phase 2, you're going on to some form of strengthening and early function. Phase 3, you're getting back to active strengthening and a lot of time balance and proprioception if you're dealing with like a lower extremity surgery. And then phase 4 is always going to be like that return to sport and high level activity. And the progression between these is based on criteria rather than just weeks, which we will take a look at here in a second. In fact, here we go. So this is from Mass General. This is a meniscus repair, I believe, protocol. So you can see rehabilitation goals, protect the repair, reduce swelling, minimize pain, restore patellar mobility, restore full extension. That would be the ability to strengthen your leg, bend the knee to about 90 degrees, and then minimize arthrogenic muscle inhibition, reestablish quad control, regain full active extension, and then educate your patient on the following. For weight bearing, you can see here, partial weight bearing, brace locked, use of crutches. And then when going up and down the stairs, it gives you even guides of what to educate the patient to do on how to go up and down stairs with the brace and crutches. You can see here the goals of this phase, which is phase 1, which lasts from approximately 0 to 3 weeks, which you can see here if you're watching, are those goals: protect the repair, protect the surgery, passively move the leg to 90 degrees. There you go. That's exactly what we were talking about in the previous slide. It makes sense. How are they going to walk? They're going to walk with partial weight bearing. That's up to the PT to explain to the patient, with a brace locked and on crutches. If we move here to the interventions that they recommend during this phase, we have RICE, ice compression and elevate. It says even here, check with the doctor regarding cold therapy if it's appropriate for the patient. Massage, ankle pumps, patellar mobilizations, seated assisted knee extension with heel slides on a towel, And heel slides on towel. I was going to say, I don't know how you do both of those things, but one is where you're seated, kicking the leg nice and straight, and that PT is coming in there and helping assist with that. And the other one is heel slides with a towel, which would be the patient laying on their back, bringing the knee towards the butt. Avoid active knee flexion to prevent hamstring strain on the posterior medial joint. So there you go. That's another thing the PT is going to try and stop you from doing, is actively using the hamstring. Seated hamstring stretch, and low intensity prone hang and heel props. For strength, that's all for range of motion. For strengthening, you're looking at quad sets, which are isometric quads. You could use electrical stimulation, straight leg raise, hip abduction, and side lying or standing, and then multi-angle isometrics at 90 and 60 degrees. Isometrics, of course, would be, meeting the force of the hand, not trying to actively kick through. Excuse me. Now, the part that those are all interventions that are recommended to the PT by the surgeon, right? So you can see here, if you were reading your protocol, let's say you were given one after surgery, you're reading through it, you can see what your day is going to look like at physical therapist. If you read this, you're like, oh, this is what PT is probably going to be doing with me. For the criteria to progress, this is what you're expected to hit around that 3 weeks. Knee extension of 0 degrees, that's full knee extension. Knee flexion range of motion of 90 degrees, quad contraction with superior patella glide and full active extension. Basically what it's saying is, can you do a straight leg raise with good patellar mobility? And then right here again, able to perform straight leg raise without quad lag. That would be your knee bending. Like it would be giving up halfway through the motion. That is your criteria to progress to phase 2, which would have its own goals. It would have its own recommended interventions. It would have its own criteria to progress. So you can see how in 2 weeks you might meet all this. You might be a PT stud, and in 2 weeks you've met all this, so it's on to phase 2. You might be really struggling, and you might not be able to get to 90 degrees, and that would guide the physical therapist to say, okay, we're going to spend a couple extra days on this. We really got to get to 90 degrees. And this is where sometimes the relationship between the PT and the patient breaks down, because the patient just feels like they're stuck, and the PT feels like they're stuck and nothing's happening. And usually the reason why this happens is because people aren't doing their homework. They think that they just show up to PT, they have all this done for them, and they can go home and do nothing. And that's not true. The homework, especially in the early phases, is what's going to get you to progress faster through those criteria and into the next phase. The PT seeing you 2 times or 3 times a week helps a lot, but it's really on the patient to get the rest of the way done. And that's one of the reasons why in the early phases, for example, I personally see people not do their homework and they don't progress as fast as they should, and they get frustrated and they wonder why they're not where their friend is in their protocol or was in their protocol. And they start saying, well, I don't understand what I'm doing wrong, blah, blah, blah. Why am I not there? And then when you say, hey, well, have you been doing your heel slides at home? And they say, no. You're like, well, then there you go. No wonder we're not at 90. I'm only moving you for 2 or 3 hours a week. It's up to you to be moving it the rest of the time. So in that sense, a protocol helps drive that conversation between the surgeon, the patient, and the physical therapist of where we should be, when we should be there, and how we're going to get there. And a good PT is going to explain to you how important and critical the homework is, because the PT can't carry you across the finish line. A lot of times a patient has to put in, well, all the time, the patient has to put in all that work at home in order to progress as much as they can. And the PT is just there to help educate and guide. And that first part saying, you should be doing these at home, but we're doing them again today. I'm going to measure and see if there's any measurable progress. And if there is, it's usually a sign that the patient has been doing their homework. And then that homework gets to change as they go through their plan of care. So how are protocols used is a lot like what I said. PTs use them as a framework, but not a strict recipe. It depends. So just like I was saying up here, those are the interventions that they recommend. A PT might be able to find a couple other exercises to sneak in there that they know from their experience or from evidence-based studies that also lead to better outcomes. So this is not an exhaustive list of the interventions that would be performed, the ones that I referenced before. That is just some of the recommendations. And a PT, as long as they keep all of the precautions that the surgeon has given them, might find some more exercises sneak in there that have some more added benefit. And that's where it's not a strict recipe. The precautions are very strict and they must be followed, but the interventions are not. Individualization is key. Like I was saying, patients heal at different rates, and not all protocols fit a patient perfectly. That's why they're general. And like I said, if you're not doing the homework, you're not going to have the progression that you want. And that's independent from even the different healing rates, because nutrition, sleep, previous level activity all play a role in how quickly a person heals and recovers. And then on top of that, if they're doing their homework, you can see how it all snowballs into better outcomes, faster recovery for a patient. The role of the physical therapist is to assess the progress, like I was saying. So day on day, I'm checking how much a person is increasing their range of motion, if their quad is getting stronger, if they're not having that quad lag, that knee bend when they're trying to do a straight leg raise, adjusting the exercise dosage. Yeah, if you come in day one, I might be having you do isometrics. I might be having you do passive range of motion only to a certain degree. And I'm trying to progress that each session. And then communicate with the surgeons, the doctors, if the patient falls behind or advances faster than expected. Absolutely. If you're falling behind as a patient that I have, I'm communicating to the doctors. I'm putting in my notes why I think it's happening so they can read that. If you're accelerating through, I'm messaging the doctor saying, hey, they're doing way better than I thought. Or way better than they should. They should be. They should be at week whatever, and they're progressing pretty darn quick. And the surgeon might say, yeah, the reason for that is the protocol that I gave you is very generalized, and the type of surgery I did is new, cutting edge, and usually people are 2 weeks ahead of where they're supposed to be according to my experience. And you're like, okay, so that will literally happen. A surgeon will say, yeah, no, I'd expect them to be a little bit ahead of where your average patient would be based on the type of surgery that I did. But the protocol that I gave you, PT, is for someone that had this surgery, but it's just the one that we have right now. Totally happens. Basically what it does is it drives that communication. It drives that discussion between the doctor, the PT, and the patient. And I wrote here, example, discussion, 2 patients after rotator cuff surgery. One follows the timeline closely. The other needs tons of modifications. That happens all the time. That happens all the time, especially if age or sport is involved. Yeah, it's very variable. Some people speed right through the protocol, not a single hiccup. Other people have nothing but what they feel like resets. And that's the name of the game. And again, that's why I harp on homework. It's a cliche, stereotypical PT answer, like it depends. But when somebody says, what's the most important thing I can do at home in physical therapy, is it's your homework. It's just do your homework, because you do 90% of the work at home in the early phases, and I only get to see you for 2 to 3 hours a week to help facilitate what you're doing. So homework is the answer, and just doing what your physical therapist prescribes you to do. That's one thing that I've seen can help even out the imbalances and progression that people see in terms of their timeline. So if they're like, my friend had this same surgery and they were done in 16 weeks, why am I on week 18 and still not where they're at? Again, I hate to be that person saying, well, you didn't do your homework. What did you expect would happen? But it's kind of the same principle as school. You didn't do your homework. What did you think was going to happen? Now, on the flip side of that, they did do their homework. They pushed too hard. They strained some things, and that set them back a couple weeks, like we talked about last episode. That's entirely possible too. So on both ends of the bell curve, the hard chargers, I'm going to get back to doing what I should do faster than I should do it, and that I'm not going to do anything and I don't feel like doing anything. You should help me get better. Both ends of that spectrum end up sometimes in the same place, and that's what's honestly very frustrating. Because a patient that is trying to do everything right, all of their homework, and then pushed it just a little bit too hard, did that one thing they shouldn't have done, and they knew they shouldn't have done it, and now they've strained it and set themselves back at least 2 weeks. That's hard, because they were so close and they tasted that finish line. They knew they were close to finishing out that phase. Now they feel like they've been reset. That's hard. That's rough. That's the mental component. And that's what, again, hopefully your PT is there saying, hey, don't do this, don't do that. I know you feel good. I know you want to, but if you do this, you can reset yourself back, and then you're stuck here an extra couple of weeks or, a month, whatever, versus motivating the other side of the bell curve. Hey, if you don't do anything, why are you expecting to get better? Those are both hard conversations. And And honestly, I know that I'm being abrasive, and I know that's probably frustrating to hear. I know it probably feels lecturing at this point, but I really, really, really wish people could understand that both ends of that spectrum can end up in the same place. And that's why the PT just harps on homework, because they're not entirely sure what you're doing at home all the time. And they say, just do your homework. That applies to both sides of the spectrum. Just do your homework. Don't go beyond the homework. Just do your homework. Be motivated enough to do something at home. All right, off my soapbox. The art. So like I was just kind of saying, the art of all this is making it patient specific. You're following the guidance from the doctor, you're following the precautions, but each patient is specific. And so like I was saying, there's that average recovery speed, which is that sweet spot that you're hoping to hit. Then there's the under challenging a patient, over challenging a patient. You never want to over challenge a patient to the point of injury, right? That could mess up the surgery and send them right back to the surgeon. No one's going to be your friend at that point. Everybody's going to be upset at you, and they should be. You failed the patient. Or you could underdose the patient. This is frustrating too. It's not nearly as bad as the other one, but it's frustrating because what you do is then you perpetually underdose the patient. You're not giving them enough stimulus to help them meet the criteria that they could meet as fast as they could. And a lot of time that's driven because of poor communication between the patient and the physical therapist, not knowing that the patient feels like they're not doing that much, like they're not being challenged enough and they could do more, which is why communication is so key. And then even if the patient says, hey, I feel like I'm being completely underdosed, then you can look at the protocol and say, oh, yeah, I'm not going to get back to doing military presses until week 6. I'm in week 1. I got to calm down here. Yeah, I guess maybe having somebody move my arm for me isn't the worst thing ever. And I guess I'm not going to be appropriate to lift weights here for a couple more weeks, right? That's the whole point of the protocol is I feel pretty good. I feel like I'm a week out from surgery. I could do a dumbbell press overhead. And it's like, no, we aren't even considering that till week 6, right? That's the conversation. That's the purpose behind this podcast episode of reading the protocol saying, oh, they're not expecting me to be able to do that until this time period. So the long story short of all this is the clinical judgment is what's necessary from the physical therapist, and the patient-centered care are essential. Because if you have clinical judgment, evidence-based studies supporting why you're doing what you're doing as a physical therapist, and you can explain that to a person, that becomes patient-centered care. Hey, I'm doing this because the evidence says that 90% of people who followed this progression or were able to do this or were able to do that got better by X time, or were able to return to this sport, or were able to return to this activity at this time period. That's what's important, right? Because that's what you as a patient want to hear from your doctor. Hey, the reason why I'm doing this is because 90% of people that did this got better in 8 weeks. Boom. That makes the patient at ease. It would make me as a PT, if I was a patient, they said, hey, this is gonna make you better in 8 weeks if you follow this guideline, boom, I'm done. I'm like, okay, I can do that. I want to be the 90%. That's the purpose of this entire episode, is to show how a physical therapist using a protocol can using their clinical judgment as well, can help progress a patient or regress a patient to meet the guidelines of the protocol, and how that's variable. And that's part of the patient-centered care here. So when you hear someone say patient-centered care, that's what they mean is they're tailoring it to you. And they're saying, hey, you were able to progress faster, so we did progress faster. That means you're ahead of schedule. Or you need a little bit more time in this phase. You're a little bit behind schedule, but that's okay. That's that clinical judgment coming from the PT, and that's that patient-centered care. They're basing their clinical judgment off of you and how you're progressing. So this has been the episode on the protocol. The vague what is it and how is it used. I hope you found it educational, informational, and maybe just a little bit complex. I apologize that I went on that soapbox tangent as long as I did about homework. But and consider looking at 10,000. They're awesome for sending that link. Now, everybody stay healthy, stay fit, and stay awesome. And I will catch you all in the next episode.